fellow audience members present. My name is Aarav, and I'm a second year MBBS student from Madras Medical College. And today I'm going to be presenting a rather interesting case on how fever refused to fade and how a routine clinical examination uncovered a rather rare complication. So, before I begin, I would first like to thank Dr. Yogesh and Dr. Jayaprakash, who are my guides for this particular case, and they have given me their permission to present on this forum today. Without further ado, I'd like to begin the case. So, we will first start with a bit of the history of the case. So, there was a certain Mr. X. He was a 40-year-old male coming from Tiruvannamalai, and he was a laborer by profession. He was transferred from Government General Med Hospital to Rajiv Gandhi with the chief complaints of the following. He had fever for the past 1 week, and abdominal pain for the past 1 week, and breathing difficulties for the last 3 days. First, he was admitted to the emergency department where his vitals were stabilized, and he was subsequently transferred to the medicine ward of our hospital. For the presenting illness, our patient was apparently normal till a week ago, after which he had developed fever, which was low grade, insidious in onset, intermittent in nature, associated with chills and rigor, and not relieved by rest or medication. He also had abdominal pain, which started about 1 week ago, and was located in the right upper quadrant. It was also insidious in onset, dull in nature, with no radiation, but it did worsen after meals. The final complaint, which we are going to expand on, is the breathing difficulty, which started 3 days prior, and it was also insidious in onset again, progressive in nature, and not associated with orthopnea, cough, or chest pain. There were no other symptoms that the patient had with respect to breathing difficulties, but he did have other positive history findings, which included generalized tiredness and decreased appetite, nausea without vomiting, and yellow discoloration of eyes and urine. The negative history would include cough with expectoration, hematemesis, bleeding manifestations, or decreased urine output. There was no other past history, family history, or medication history findings, which possibly indicated that this was not a genetic condition and that the patient was not not an exacerbation of a pre-existing condition. With respect to the personal history, our patient was a known consumer of alcohol. He had been consuming about 175 ml every 2 days for the last 10 years. And he had reported to have his last drink about 6 months ago. He also gave us a history of smoking for about 10 pack years. To give an insight as to what pack years are, one pack year would indicate that the patient smokes on average one cigarette packet per day for a particular year. So that would be one pack year, and our patient has 10 pack years. The patient takes a mixed diet, which includes both non-vegetarian and vegetarian foods, and he did not have any abnormal bladder or bowel. With respect to the examination findings, we first start with general examination. Our patient was conscious, oriented, well built, and well nourished. There was icterus noted, but there was no pallor, cyanosis clubbing, edema, or generalized lymphadenopathy. There were a few perioral lesions that were noted. As for the vitals, his pulse rate was about 120 beats per minute. His blood pressure was slightly decreased with about 100 over 80 millimeters of mercury, and our patient was tachypneic as his respiratory rate was increased to about 22 cycles per minute. And at the current time of examination, he was febrile. With respect to local examination, we noticed a painless black necrotic scar or ulcerated lesion over the chest wall, which is located towards the left side. It was located at the lower one-third aspect of the sternum, and it measured approximately 0.5 cross 0.5 centimeters. There were no other petechiae, purpura, or ecchymosis associated with this, which indicates that there is no vascular abnormalities, because that would indicate like some bleeding abnormality. With respect to the systemic examination, we performed complete systemic examination with significant findings coming to his respiratory system. As I said earlier, he was tachypneic, and also with respect to the abdomen, as soft. There was mild tenderness or right hypochondrium, as the patient had complained earlier. There were normal bowel sounds heard. The cardiovascular, musculoskeletal, and central nervous system findings were all within normal range. So, after the history and the examination, we usually come to a provisional diagnosis of what the patient might have. So, based on these, we were thinking of the possible differential. It could be tropical infections, as are very common in our locality. And these tropical infections could range from leptospirosis, strep typhus to brucellosis. It could also be a liver abscess due to the fever, ictus, right upper quadrant pain that the patient was having, and that it could be acute cholangitis as well, which is due to similar findings. And alcoholic hepatitis could also not be ruled out, as he is a known consumer of alcohol, and the liver findings also indicate something similar. So, based on these differentials, we will further move into the investigations that we order for the patient. The first investigation that we usually order is a complete blood count. As you can see over here, his red blood cells, white blood cells, and hemoglobin are decreased. And from the report over here, you should also be able to see that the platelet counts are also significantly decreased to about 31, which is supposed to be in the range of 150 to 450. So that gives us a pancytopenic picture, which indicates that all the cell lines which are responsible for the blood cell synthesis are decreased. There's also decreased hematocrit and active lymphocytes. These are the reasons I had just said. The second thing would be a coagulation profile, which is also a marker of the ability of the liver to synthesize the coagulation factors. Activated partial thromboplastin time was decreased, but prothrombin time was increased. APTT is an indicator of the intrinsic pathway, and PP is an indicator of the extrinsic pathway. The international normalized ratio was normal, and it's usually kind of standard to measure how bad the coagulation profile is. Yeah, the liver function tests, which showed that the AST and ALT were elevated. Renal function tests included elevated urea and creatinine. And one of the most important investigations that we ordered, since we suspected an infectious cause for this, was the culture and sensitivity testing. Viral test is typically done for typhoid. Usually, since the patient has come to us in about the second week after complaints of infection, viral test becomes the gold standard. If it was done in the first week, we would go for something like a blood culture. The NS1, NS2 antigens for dengue were negative. Standard agglutination tests were negative for brucellosis, but the IgM for scrub typhus was positive, and the matrix agglutination test was positive for leptospirosis. And when doing speciation, we found that it was leptospirosis interrogans autumnalis. So, based on the findings we've seen over here, we've come to the provisional diagnosis that our patient is suffering from mixed tropical infection, both scrub typhus and leptospirosis. The management indicated for both of these diseases is doxycycline, of which 100 milligrams is given twice a day. Paracetamol is given for the fever, 5 milligrams twice a day. And azithromycin is a usual adjunctive therapy that you also give in addition to doxycycline when we suspect a severe infection of the scrub typhus or leptospirosis. Seeing that he had both, we opted for that treatment as well. The interesting thing to note that after, in spite of the treatment that was given to the patient, he unfortunately was not improving. So from this particular slide that we are looking at, we can see over here, I don't know, is everybody see my cursor?
Yeah.
Yes.
Yes. So as you can see, day 3 is the day he was admitted to us. And day 10 is the day we are looking at right now. So as you can see, there's still a persistent decline in the hemoglobin, hematocrit, white blood cells, and platelet count. He's not improving this. So other causes of this would probably be some bloodborne infections such as hepatitis, since he had liver findings as well. So we screened him for hepatitis A, E, B, and C, and none of them showed any positive of antigen antibody tests. None of them came out positive. Blood culture and sensitivity for other organisms did not show any growth. The liver function tests also show a similar picture as to what we've seen earlier with the AST and ALT elevated. So based on this, we opted for some further investigations, a repeat peripheral smear, which showed dimorphic anemia, which is implicit in the previous slide that we have seen in the decreasing counts. On visualization, they were normocytic normochromic with macrocytes and anisopotylocytose. The eureka of this particular case would be coming on 7th day when during ward rounds, we happened to find an enlarged spleen while clinically examination the patient. Now, this suggested splenomegaly. So, in light of this relatively new finding, we ordered a USG scan, ultrasound, which was confirming the presence of this enlarged spleen. And based on this, we further opted for an abdominal CECT. Now, in the CECT over here, what we could see was multiple hyperdense lesions in the 7th segment of the right lobe of the liver. And these particular findings, as confirmed by radiology, were indicative of multiple liver hemangiomas. The splenic index was also found to be extremely enlarged, which is about 1,368, which is quite a large size. But again, that is subjective based on the patient. Other investigations included these. Since we could see that the patient was not improving on doxycycline, and with the clinical and CECD findings, we started shifting our focus towards something like hemophagocytic lymphohistiocytosis. But there were some other conditions, infectious causes especially, that we had to rule out first. One was cytomegalovirus and Epstein-Barr virus, parvovirus B19, which were all negative. It could have also been malaria, but the peripheral smear, as we'd seen earlier, did not show any malarial parasites. And a bone marrow biopsy that was done showed some erythroid hypoplasia, which is a response to the anemia that is seen in particular patient. In order to conclude, or in order to justify that the patient really did have HLH, we opted for these three particular tests, triglycerides, fibrinogen, and ferritin, of which triglycerides and ferritin were elevated, and the fibrinogen was decreased, hypofibrinogenemia. And these three findings were indicative of hemophagocytic lymphohistiocytosis. So, based on these clinical findings that we have seen previously and the investigations that we have done, we came to the conclusion that our patient, a 40-year-old male, had developed hemophagocytic lymphohistiocytosis secondary to an infection of strep typhus and leptospirosis. And he also had multiple liver hemangioma. So, a bit of discussion as to what HLH exactly is. Hemophagocytic lymphohistiocytosis is a hyperinflammatory syndrome, which is basically how our immune system is responding to a certain infection. It's a hyperreactive response. Hyperreactive response. So when we say hyperreaction, there's an increased number of cytokines that are being released, which is causing our patient to, have symptoms such as fever, pancytopenia, and all sorts of things. This is primarily classified into two types. We have the familial type and the acquired type. The familial type, as the name suggests, it begins during infancy after birth, and these are due to mutations. For example, in genes such as PRF1 and UNC1, the 1,3B. The acquired form can be due to infections, or it can be due to therapy or transplant, or it can also be due to cancer as well. That is called malignancy-related HLH. The most common trigger, I should say, rather, for the secondary type is the Epstein-Barr virus, which is negative in our case, but it can also be due to non-infectious causes such as autoimmune disease and hematological malignancies, as I discussed earlier. So, as I was saying earlier, why it occurs is because there is a trigger. Now, for example, this could be infections. Let us take our case, for example, this is infection. So this trigger activates the natural killer cells and the cytotoxic T lymphocytes. So the activation mechanism is based on the increase in interferon gamma. Now, interferon gamma is going to activate your macrophages, and it's tests. The liver function tests, which showed that the AST and ALT were elevated. Renal function tests included elevated urea and creatinine. And one of the most important investigations that we ordered, since we suspected an infectious cause for this was the culture and sensitivity testing. Uh, viral test is typically done for typhoid. Usually, since the patient has come to us in about the second week after complaints of infection, viral test becomes the gold standard. If it was done in the first week, we would go for something like a blood culture. Uh, the NS1, NS2 antigens for dengue were negative. Standard agglutination tests were negative for brucellosis, but the IgM for scrub typhus was positive, and the matrix agglutination test was positive for leptospirosis. And when doing speciation, we found that it was leptospirosis interrogans autonomous. So, based on the findings we've seen over here, we've come to the provisional diagnosis that our patient is suffering from mixed tropical infection, both scrub typhus and leptospirosis. The management indicated for both of these diseases is doxycycline, of which 100 milligrams is given twice a day. Paracetamol is given for the fever, 5 milligrams twice a day. And azithromycin is a usual adjunctive therapy that you also give in addition to doxycycline when we suspect a severe infection of the scrub typhus or leptospirosis. Seeing that he had both, we opted for that treatment as well. The interesting thing to note that after, in spite of the treatment that was given to the patient, he unfortunately was not improving. So from this particular slide that we are looking at, we can see over here, I don't know, is everybody see my cursor?
Yes.
Yes. So as you can see, day 3 is the day he was admitted to us. And day 10 is the day we are looking at right now. So as you can see, there's still a persistent decline in the hemoglobin, hematocrit, white blood cells, and platelet count. He's not improving this. So other causes of this would probably be some bloodborne infections such as hepatitis, since he had liver findings as well. So we screened him for hepatitis A, E, B, and C, and none of them showed any positive, antigen antibody tests. None of them came out positive. Blood culture and sensitivity for other organisms did not show any growth. The liver function tests also show a similar picture as to what we've seen earlier with the AST and ALT elevated. So based on this, we opted for some further investigations, a repeat peripheral smear, which showed dimorphic anemia, which is implicit in the previous slide that we had seen in the decreasing counts. On visualization, they were normocytic normochromic with macrocytes and anisopotylocytose. The eureka of this particular case would be coming on 7th day when during ward rounds, we happened to find an enlarged spleen while clinically examination the patient. Now, this suggested splenomegaly. So, in light of this relatively new finding, we ordered a USG scan, ultrasound, which was confirming the presence of this enlarged spleen. And based on this, we further opted for an abdominal CECT. Now, in the CECT over here, what we could see was multiple hyperdense lesions in the 7th segment of the right lobe of the liver. And these particular findings, as confirmed by radiology, were indicative of multiple liver hemangiomas. The splenic index was also found to be extremely enlarged, which is about 1368, which is quite a large size. But again, that is subjective based on the patient. Other investigations included these. Since we could see that the patient was not improving on doxycycline, and with the clinical and CECD findings, we started shifting our focus towards something like hemophagocytic lymphohistiocytosis. But there were some other conditions, infectious causes especially, that we had to rule out first. One was cytomegalovirus and Epstein-Barr virus, parvovirus B19, which were all negative. It could have also been malaria, but the peripheral smear, as we'd seen earlier, did not show any malarial parasites. And a bone marrow biopsy that was done showed some erythroid hypoplasia, which is a response to the anemia that is seen in particular patient. In order to conclude, or in order to justify that the patient really did have HLH, we opted for these 3 particular tests: triglycerides, fibrinogen, and ferritin, of which triglycerides and ferritin were elevated, and the fibrinogen was decreased, hypofibrinogenemia. And these 3 findings were indicative of hemophagocytic lymphohistiocytosis. So, based on these clinical findings that we have seen previously and the investigations that we have done, we came to the conclusion that a patient, a 40-year-old male, had developed hemophagocytic lymphohistiocytosis secondary to an infection of strep typhus and leptospirosis. And he also had multiple liver hemangioma. So, a bit of discussion as to what HLH exactly is. Hemophagocytic lymphohistiocytosis is a hyperinflammatory syndrome, which is basically how our immune system is responding to a certain infection. It's a hyperreactive response. Sorry, hyperreactive response. So when we say hyperreaction, there's an increased number of cytokines that are being released, which is causing our patient to, have symptoms such as fever, pancytopenia, and all sorts. This is primarily classified into two types. We have the familial type and the acquired type. The familial type, as the name suggests, it begins during infancy after birth, and these are due to mutations, for example, in genes such as PRF1 and UNC1, the 133. The acquired form can be due to infections, or it can be due to therapy or transplant, or it can also be due to cancer as well. That is called malignancy-related HLH. The most common trigger, I should say, rather, for the secondary type is the Epstein-Barr virus, which is negative in our case, but it can also be due to non-infectious causes such as autoimmune disease and hematological malignancies, as I discussed earlier. So, as I was saying earlier, why it occurs is because there is a trigger. Now, for example, this could be infections. Let us take our case, for example, there's an infection. So this trigger activates the natural killer cells and the cytotoxic T lymphocytes. So the activation mechanism is based on the increase in interferon gamma. Now, interferon gamma is going to activate your macrophages. As I was saying, interferon gamma is responsible for the activation of macrophages, and now macrophages are going to engulf the infectious cause as they normally do, and they release a lot of high inflammatory mediators such as human necrosis factor, interleukin 6, 1, and 10, which are responsible for fever and the hyperinflammatory syndrome I was discussing. HLH or MAS, as you can see here, HLH is hemophagocytic lymphohistiocytosis. MAS is macrophage activation syndrome, which is a syndrome that is quite similar to the one that we are seeing over here, but it usually results due to other causes, probably such as chemotherapy. Sorry, not chemotherapy, cancer-induced HLH. So coming back to our case, the points for diagnosis of HLH are based on the HLH criteria 2024. There need to be a minimum of 5 out of 7 criteria to fit. Out of these, fever, splenomegaly, cytopenias, hypertriglyceridemia or hypoproliferative and ferritin were present in our patient. Hemophagocytosis was not done since the first of these 5 were initially positive. So we initiated treatment almost immediately. And the patient was this becoming much worse, as you could see earlier, day by day. So it was imperative that we had tried to start the treatment as fast as possible. The other parameter which comes under the criteria is an elevated soluble CD25. An important point to note is that compared to the 2004 criteria, we have removed NF-kappa B cells. So they are no longer required for us to diagnose someone with HLH. So we have only 5 out of 7 as of now. And those are the references for that claim is down below. Yes. So back to our case. Based on what we have seen earlier, diagnosed with HLH. The management for HLH in this case was steroids. And steroids, as you know, they reduce the hyperinflammatory response. They are immunosuppressants. So we gave him dexamethasone 8 milligrams once daily. And he was continued with his existing antimicrobial therapy of doxycycline and azithromycin. We monitored him further for vitals and recurrence of fever was done. He was discharged very soon as he had immediately begun to improve the steroids, confirming our diagnosis as earlier. And after he was discharged, he was recommended to come back for follow-up for 4 weeks, and there were no other abnormalities or no other complaints by the patient, and he was subsequently discharged. The most important part of the case, of any case for that matter, would be how relevant it is to us as patients. HLH is a condition that can prove to be fatal in nearly 40% of the cases, as it can move for a very, very grave prognosis. So the key to first curing someone from HLH is to diagnose it as early as possible and initiate treatment as early as possible. And if there's persistent fever and pancytopenia, especially, in spite of the ongoing treatment, then HLH must be considered as possible diagnosis as soon as possible. Co-infection of multiple tropical infections are quite rare, as scrub typhus and leptospirosis are a unique combination, and the factor that develop into HLH is even rare. So these kind of cases must be monitored for appropriate treatment, as antimicrobial susceptibility must be done for the particular organisms that we're giving treatment for. Clinical examination and follow-up of patients during ward rounds help diagnose and detect disease progression. As you could see, during clinical ward rounds, we were able to detect the splenomegaly that changed the course of our diagnosis completely, rather. And we were able to find out that the patient did have HLH and treat him as soon as possible. So with this, that concludes my presentation. Thank you, everybody, for your patient listening.
Thank you, Aarav. So over to the judges for comments.
Yeah, I have a few questions. It was
Yes,
a
sir.
good presentation overall. You mentioned patient was having fever. Do you have a record of how high the temperature went up? And then do you have a temperature curve as to the temperature was persistent or fluctuating? Is it
I do not
documented?
have a documented curve, sir, but I could tell you the exact pattern. So what actually happened was when he came to us, he did have fever, and it was, as far as I can remember, it was 104 degrees at that point of time. Subsequent measurements, I'm not really sure of. But what happened was he started recovering, and then there was an intermediate pause, and then he again had fever subsequently after that. So it was a very intermittent sort of pattern. It did not fall into a very particular pattern as probably like tertian or portion or any of those particular patterns. But it was, in a sense, intermittent because he was like having fever for half a day, and then it recovered, and then he again had fever for after 2 days. So it was a sort of mixed pattern, but we could call it intermittent because it's not continuous.
Yeah, in your presentation, it'll be helpful if you have a graph to see the temperature fluctuation
All right,
instead of just saying low grade temperature.
I'll keep that in mind.
The other question is, I'm not very familiar with this disease.
Mhm.
You said the patient presented with fever and abdominal pain,
Yes, sir.
and the pain was on the right side. So how do you
Yes, sir.
explain the right-sided pain, where the splenomegaly was on the left side?
Sir, the right upper quadrant pain is a characteristic feature of leptospirosis. You can see right upper quadrant pain in leptospirosis, and splenomegaly is something that you find in cases of scrub typhus. So the most probable reasoning for this in our particular case is the patient initially did have certain splenomegaly that was initially subclinical when he was admitted to us. The HLH which he had developed after this just made the spleen much larger, and now it was much more clinically palpable. So that is the explanation for that's the most probable explanation for us seeing the splenomegaly nearly 7 days later, even though it was probably there initially, because that is a consequence of scrub typhus itself. The right upper quadrant pain is definitely a characteristic of the leptospirosis infection, and that's why you see jaundice in this patient as well.
The one other question is, you mentioned physical exam, and you were able to pick up this skin lesion. That's a
Yes,
very
sir.
good finding.
Yes.
But I noticed that you haven't described
Yes.
general physical exam. For example, patients presenting with unexplained fever can have soft tissue abscesses, especially in the perirectal areas, and also the examination of the spine. You can have discitis. You won't find that unless you palpate the spine. So those are the things. It may not matter in this particular case. For completion's sake, you need to mention all that in your discussion.
Okay.
Thank you.
Thank you.
Aarav,
Yes, sir.
I enjoyed your presentation.
Thank you, sir.
I think it was very crisp, very clear, and I want to compliment you on an excellent presentation. I was kind of impressed that when a patient presents with fever and jaundice and right-sided abdominal pain pointing to a problem with the liver, that of course most of us would think of something like infective hepatitis or Hep A as the most likely diagnosis. And I was impressed that right from the beginning, you thought about things like leptospirosis and scrub typhus, which all said and done is not that common. Now, I don't know this. Perhaps you could enlighten me. Is this because he is from an endemic area? I mean, is this area
Yes, sir.
known to have a lot of typhus and leptospirosis?
Exactly, sir. That is the case.
So he
yes.
is from an endemic area.
Yes.
I didn't know that. I didn't know
So
that.
there's Tiruvannamalai belt actually towards the east coast. It's notorious for many patients coming to us with scrub typhus infection, especially. We get a lot of patients over there, and his symptoms also seem to match somewhat to that. So
I see.
yeah, and leptospirosis is also something that's really common nowadays.
Yeah, I know that about a year ago, there was a paper published in the New England Journal of Medicine from Vellore, where they did an epidemiological study of typhus in the general area. And I know that in and around Vellore, there is a high incidence of typhus. Now, if he was positive for leptospirosis, did you then also consider Hanta fever? Because the two of them can often coexist.
Uh, that would not have been our initial thoughts. We did not think of that actually. And probably if he had tested negative for scrub typhus or lepto, we probably could have thought further about those kind of infections, but that wasn't our first thought because right now these are the dengue, malaria, as you know, and these two infections as well are the first infections that are really common nowadays coming to us in the wards. So these are the
I
first things
see.
we investigated for, and they came out to be positive as well. So that just strengthened the diagnosis further.
Now, were there any other members of his family or friends or co-workers who had any of these infections?
Not
Is there
that I'm
any
aware.
do you have any information about that?
No, sir, not that I'm aware of. The patient he came from like a really distant area, so he brought a lot of family members with him. His uncle was there, his brother was there, his wife was there, all of them were there. But none of them were tested positive for any of this. None of them showed symptoms. And there's no information as to his co-workers either. So, yeah.
I see. I see. Okay. Look, very good presentation, and you came to some very logical conclusions. I enjoyed your presentation. That's all I have to say. Thank you.
Thank you, sir.
Can we have the comments from Dr. Jayavelan? Jayavelan, sir.
Yes, madam.
So please, sir, your comments, sir.
It's a very good presentation. Congratulations. As pointed out by the earlier speaker, it is better to include all common things like temperature chart. That will be very useful for early diagnosis.
Okay, sir.
Thank you. All the best.
Oh, yes.
Thank you, sir. Can we have the comments from Dr. Vijay Shankar, please, sir?
Yeah. Apart from what are the other markers of infection did you check in this patient, doctor?
In what sense? So markers in the laboratory or clinical? What do you mean, sir? We did other investigation findings, I think, but get to the page. Yeah, we did other investigation findings such as the Vidal test, NS1, NS2, SAT. We also showed later that we did the immunoglobulin M for CMV, BB, parvovirus B19. We also did peripheral smears bone marrow biopsy was done. So these are the other findings that you could have infections with. Clinically, there's not much else you can do when it comes to infection. The conclusive diagnosis is obviously lab investigation. So these are the other ones that we have done, but all of them are negative, as you can see.
I think you pointed out some 7 points, out of which 5 were positive. Could you
Yes,
show
ma'am.
that slide once again?
Yes, ma'am. 1 second. This is the slide, ma'am.
Oh, yeah.
This is the criteria to diagnose someone with the HLH as of 2024. This is the latest update.
So you had 5 out of 7.
Yes, ma'am. That is
How
the
many should normally minimum, or how many should be present?
minimum is 5, ma'am. Minimum is 5.
Minimum is 5. So yours
Yes.
is meeting the criteria.
Yes, ma'am.
Ma'am, can I ask a few questions?
Yes, Praveen.
So it was a nice presentation, Aarav.
Yes.
So my question to you is that first you touched upon splenomegaly.
Yes, sir.
So what is the difference between hypersplenism and splenomegaly?
So splenomegaly is just an enlargement of the spleen that you see. Hypersplenism is increased activity of the spleen. So there will be increased phagocytosis within the spleen. Hypersplenism is usually accompanied with splenomegaly, but sometimes it could just be there by itself.
So what kind of peripheral blood picture will you see in hypersplenism?
Hypersplenism.
Hypersplenism.
You would see anemia, obviously, because there's increased phagocytosis. You'll see a pancytopenic picture again, because most of the formed elements that are entering into the spleen are now getting damaged. Because of the damaged RBCs, now you could see even jaundice as well, icterus as well, because the bilirubin form will be unconjugated. Apart from that,
okay, that's good. That's good. Yes. So next question is that what is the most common examination finding in a patient whom you suspect of scrub typhus?
The most common examination finding. So
yes.
You can see an eschar.
Where will you find the eschar?
Eschar is normally the place where the leprothrombium mite has bitten us. So that is the place where the microbe enters into our body, and that forms an eschar around that area.
It is usually in areas where you
yes, where sweat a lot, armpits. Yes,
groin.
Yes, sir.
So
hidden areas where the sweat is a lot. That's the usual areas where you find it.
There's a term for it. I'm not able to recollect it at the moment. There's a particular term for it. Are you able to recollect it?
No, sir, I have not come across that.
There's a particular term to it. The covered areas of the body where you will be able to find the eschar. So from my clinical experience, which I have had as an intern, when I was posted in internal medicine, it was in the months between November and December. Okay, so I have seen somewhere around 15 to 20 scrub typhus patients getting admitted in a span of around a couple of months. So what we'll do is that you will present to the mild hyponatremia. He will present to the mild hyponatremia, and I have seen multiple cases presenting with encephalopathy. Okay, so just I'm sharing my experience. So that's it from my side.
Thank you.
It was a nice presentation.
Yeah, thank you, Praveen.
Yes,
Sir, judges, any more comments, any more questions from the judges?
I have a question for the presenter. Excellent presentation. Congratulations. You said it is systemic. Are there any vaccines in the process of availability, or they are making it? Do you know?
For script, I think there are some vaccines that are being made for leptospirosis, but none of them have been used in the market as of now. None of them have shown any proof in clinical trials well yet. They've not been released. So we are resorting more to management using antimicrobial.
So there is no vaccine in the pipeline?
They are in development. As far when I researched, they were in development, sir. None of them were actually being used routinely in hospitals. So that's all I know about vaccine.
Okay, thank you.
So thank you, Aarav.